Welcome to part 2 of chapter 25 on integrated physiology of exercise. We're going to pick up where we left off last time when it comes to limiting factors of exercise and then ventilatory and other aspects of physiology that are involved in exercise. As we've mentioned before, there's often a lag between when we are able to sustain exercise with oxygen supply. Like for instance, at around if exercise begins here, we often go into a deficit depending on the intensity of the exercise. In some ways, that's partly why warming up can be really important, because you're working at a lower intensity and the steepness and the depth of the deficit is less, and you can improve performance that way. On the back end, we have a little bit of lag where what we're doing post-exercise is restoring energy storage systems. That includes creatine kinase and the phosphocreatine, as well as myoglobin. And also clearing out metabolites like lactic acid or other organic acids. So we have a little bit of lag at the beginning, and we also have a little bit of lag at the end. Now, the only thing I don't like about this figure to a certain extent is that it's very rare that you would just immediately ensue with exercise without any of that sort of feed-forward mechanism, if you know what I mean. So much of the time when we're talking about exercise, we talk about being in shape or out of shape or that sort of a thing. Well, this directly plays into that aspect. The factors that limit, shall we say, sustained exercise, because virtually anybody can exert for a period of time, and sometimes that time can be exceedingly short. Somebody who is in very bad form may only be able to exert physically for just a few seconds, maybe a minute or so, or 2 minutes. But folks that are in shape can sustain submaximal exercise for quite a long time. If you think about ultramarathoners and triathletes and those sorts of things, they have conditioned their bodies to sustain submaximal exercise for an extended period of time. And one of those factors is the ability of the cardiovascular system. If the heart can deliver cardiac output, it means that it can deliver oxygen and nutrients to the muscle that will support its aerobic activities. To be able to deliver, this is sort of the cue, if you will, to muscle. If we talk about VQ ratio, you remember that? Well, this is the perfusion and the delivery of blood to the tissues in order to sustain oxidative phosphorylation. So exercise can and does cause responses that can then lead to adaptations. For instance, someone who is in good shape will have a stronger vasodilation response. That is to say, their blood vessels will dilate more than somebody who isn't in good form. The capillary density, again, angiogenesis is the term here. Someone who has not been exercising all that much will not have as dense or as extensive a capillary bed. And then we're going to talk about this a little bit later. This is this insulin-independent ability to bring glucose into the muscles. We know that insulin will allow glucose to come into the muscles, but again, we have this mechanism of glucose independent. And again, I'll show you that mechanism in a few slides. So, exercise, facilitating aerobic activity, and so forth, will cause these chronic adaptations, physiologic adaptations that we've talked about all semester, that will then result in differential signaling and long-term responses. For instance, if we don't need insulin as much, we're not going to release as much insulin. And so our insulin parameters, HbA1, if you hear about A1C, okay, blood glucose will drop a little bit. Why? Because the muscle is absorbing that glucose better without insulin. All right. The other side of it, and we don't really have time to talk about this, but chronic high blood sugar and in combination with high triglycerides leads to damage in sensitive tissues, including your eyes, certainly your heart, and your neuronal systems, your nervous system. We call this glucolipotoxicity. We often think of lipids as bad, but the combination of high glucose, high lipids seems to be problematic in certain tissues. And so if we can lower blood glucose, if we can improve blood flow, and we're handling fats and metabolizing them, this leads to less complications associated with sedentary lifestyle. This is all found in a really, really nice article right here. It's a nice review article for you if you're interested in this topic, and hopefully you are. Next, let's move to ventilatory responses. And ventilatory responses are really, really interesting because they will precede exercise oftentimes. And you heard my criticism from an earlier slide. So we have feed-forward aspect here, but we also have lag, similar to that previous slide. This is an interplay between your central nervous system and your peripheral sensory and sympathetic, parasympathetic nervous system. Your memory, your cognitive centers will know that you are about to undergo exercise and will thus trigger sympathetic responses, leading to this sort of feed-forward ventilatory response. But as we engage in exercise, chemoreceptors, proprioreceptors, mechanoreceptors all add to this and lead to an even greater rate. So while our breathing rate goes up, because our metabolic need, if we didn't undergo exercise, let's say we were anticipating we were going to do exercise, and then we did. What you would see is you would see this come back down because there isn't any reinforcement. Okay, so these reinforce that feed forward into a departure from our basal state. And then when we stop, what happens is our metabolic needs drop, these signals cessate, and we begin restoring our energy supplies and or metabolizing organic acids produced during the exercise. So that lag, if you will, is a restoration of energy storage, oxygen storage in muscles, as well as oxidative and enzymatic metabolism of things like lactic acid and other metabolites, restoration of calcium in the muscle, movement of sodium and potassium, and so forth. Again, this is your figure from the book. What it doesn't show is that feed-forward mechanism that I was just showing. So if, surprise, we're going to exercise, okay, let's say, for instance, you were in a building and the fire alarm suddenly kicked in, you wouldn't have that feed-forward aspect. You would immediately begin exercise, and thus you would see the compensatory response. That would be due to, again, the chemoreceptors in the blood, the proprio and mechanoreceptors in muscles and tissues that then trigger this. And again, there's the lag, though. Again, the reason for the lag is, again, restoration of oxygen in myoglobin. Okay, the metabolism of lactic acid and metabolites of exercise, restoration of resting membrane potential, resupplying the creatine phosphate in muscle. Now there's only one more thing to add to this list. So we now have talked about this part. What's left is, and this is a really interesting point, is that even though we're increasing rate and depth, so we're massively increasing our ventilation capacity, if you will, our exchange of gases, especially in heavy exercise, it turns out that these three values here, PO2, PCO2, and pH, do not significantly change. They are rock steady. So even though we're having large changes, and we'll talk about heart rate in a little bit and so forth, and large changes in volume moved, they are merely sustaining the homeostatic set points that we have in the bloodstream and in terms of our oxygen, carbon dioxide, and pH. Now these graphs here are all on the same axis, and the axis here, the x-axis, is oxygen consumption within the cells. All right, oxygen consumption within the tissues. And this is synonymous with intensity of exercise. All right, this is synonymous with intensity of exercise. So 100% oxygen consumption is 100% maximal intensity. What you see here is that we have ventilation rate can go right through the roof from, less than 10 per minute, 5 to 6 per minute, all the way up to 140 per minute with maximal activity. Not showing hard on here, but even though we're ventilating like crazy, look how rock steady our O2 is. That's because oxygen consumption is rising, and we are compensating with increased ventilation to keep the arterial blood steady. All right, keeping the arterial PO2 steady at around 100 millimeters of mercury. All right. CO2 is a similar story, though what we see is that with increased ventilation, we do see a slight decline in PCO2 just because of the sheer amount of ventilation. Also, when you get to this level, what's happening is you're doing more and more anaerobic activity. So in some ways, the power that's being generated here is sort of outside of oxygen consumption, if you will. So we're actually seeing some power that's not even attributable to creating CO2. So maybe in some ways that's why it's dropping a little bit. But it's certainly due to this very, very high level of ventilation. Venous PO2 is still dropping though. So we're still using a lot of oxygen there. So we're returning less oxygen to the lungs. But we can with this high ventilation, we can keep that arterial PO2, which is the delivery, if you will, fairly solid. pH here you'll see drop, and it's not obviously due to an increase in carbon dioxide. This is due to an increase in other organic acids. Certainly lactic acid is one, but there are plenty of other organic byproducts of intense exercise that we really don't have time to talk about. So we do see a drop in pH, and this is mostly metabolic type pH rather than, shall we say, respiratory type pH. One more thing to note, these questions down here are really, really good. I strongly recommend in this chapter that you go through the book questions and not only get the answers correct, but understand why the answers are correct. Looking at distribution of blood flow, remember that when we're talking about blood flow, we're talking about a combination of cardiac output and peripheral resistance. In general, when we have exercise, the sum, if you will, of peripheral resistance is lower. We reduce peripheral resistance, but the problem is if that's all we did, pressure would plummet and the person would pass out. So what happens is we have the balance between increased cardiac output and overall reduction in peripheral resistance, because when we vasodilate, we lower resistance. So we have increased cardiac output, decreased summation of peripheral resistance, but the distribution pattern changes. So when you're looking at different flows to different organ systems, what you'll see is that although it looks like blood flow is dropping to the brain, if we do a quick calculation, so if we look at the brain over here on this side, it's getting 13% of our cardiac output. So 13% times 5.8. 0.13 times 5.8 is about 3/4 of a liter per minute. If we look on the exercise side, we take 3% times 25.6 liters per minute, so 0.03 times 25.6, and we have a blood flow of just around the same. It doesn't change all that much. Relatively minor change to 0.77. On the other hand, let's look at skeletal muscle down here at the bottom. So we got skeletal muscle right here, which gets about 1/5 of the blood flow, 21%. Calculate that out, that's a little more, 1.25 liters per minute, 1.22. In exercise, blood flow is 88%. So it looks like it's about at least a four-fold change. No, because when we have 25.6 liters per minute cardiac output, it's actually 22.5 liters per minute. So almost a 20-fold change, give or take, in blood flow. Some organ systems will have relatively stable blood flow before and after exercise, certainly the critical things. But other things, like for instance GI, we might have quite a lot of blood flow, about a quarter of this, but only 1%. So there's a diminish here. This is one of the reasons why the old saw about saying wait 20 minutes to go swimming after you've had a meal. Because when you eat, blood flow is often shunted to your gastrointestinal tract. If you start to exercise, that blood flow will shut down, and that can lead to stasis in the GI tract, which can lead to indigestion and others, and cramps and that sort of a thing. Okay, so we get differential blood flow, but the big picture in terms of systemic is that we have reduced systemic peripheral resistance combined with increased cardiac output. When it comes to cardiovascular responses to exercise, we're all familiar, we can all feel our heart rates going up. Cardiac output is certainly rising as we move into exercise in order to meet metabolic need. And it's a combination of heart rate and stroke volume. That's what cardiac output is. It's how often it's squeezing and how much it's squeezing when it does. Well, let's look at the mechanisms that drive that. We've talked about this during the semester. SA node, which is stimulated by a number of stimuli, but we're just going to focus on the SA node right now. The I sub F, that funny current. I subscript F, funny current, it gets steeper, which means that the SA node is firing off P waves or initiating P waves quicker than it would otherwise. Again, that can be due to autonomic nervous system input, it can be due to epinephrine, some other things. In terms of autonomic nervous system input, we're also increasing the strength of the cardiac contractions, and we are generally, not entirely, because you saw that some vessels dilate and some constrict, we are generally increasing the calcium kinetics, particularly in the heart. All right, we're getting faster calcium waves in the heart, which lead to stronger, more rapid contractions. Venous return, that's calcium kinetics in the large veins. That's the smooth muscle constriction, sympathetic input here. We're also getting more return in blood just due to the fact that the skeletal muscles are squeezing, and they're squeezing those veins and pushing blood back to the heart by skeletal muscle contraction. Again, we've talked about all of these mechanisms. Now it's time to put it together. We all know about exercise. Let's put these mechanisms into play. One more thing about cardiovascular response. If we have more venous return, that means that the myocytes in the cardiac muscle are going to get stretched more. Length-tension relationship, the Frank-Starling law. So as we extend that sarcomere, we're going to get an increase in contractile force. So these are all working together. Faster rate, stronger contraction, stronger contraction, stronger contraction, stronger contraction, because we're bringing more blood back to the heart. So a combination of these things are what's driving the heart rate, but also the stroke volume. And it's that interplay that we need to understand. Obviously, we're also going to have a change in peripheral resistance. Overall, peripheral resistance drops. Systemic peripheral resistance drops. That sort of balances out cardiac output so that we don't stroke out when we have that increased cardiac output. All right, but it's differential. Some are going to dilate, like for instance, skeletal muscle, we're going to dilate, so we're going to get a huge increase in blood flow to muscle where we need it metabolically. Things that are critical organ systems like the brain, relatively stable. But then when we talk about other systems that are not critical, like digestive tract, we increase resistance. But as a whole, what we're doing is we're decreasing total systemic resistance. And that's what we're seeing here. We saw this figure. We're just looking at it from an exercise paradigm. As we start to exercise, we get a change in blood pressure, and we're going to get those responses like we saw. Okay, an increased pressure, we're going to lead to vasodilation in some cases. If we're going to get increased venous return, we might have faster rate, stronger contraction. ISABF funny current, calcium kinetics in these areas. Again, in response to the stretches as well as the sympathetic and parasympathetic signals. So peripheral resistance, systemic peripheral resistance, not individual organ system peripheral resistance, generally decreases due to the fact that we are vasodilating muscle. So as we increase exercise intensity, peripheral resistance tends to drop. And a great graph question here. If peripheral resistance is falling, but peripheral blood pressure rises, what must be happening to cardiac output? It has to be balancing this drop in peripheral resistance. So what we see is that we only have a relative, we do see a rise in systolic pressure. That's said. Diastolic pressure rises a little bit and mean rises a little bit, but it's not as severe as, say, the change in cardiac output or the change in peripheral resistance. That means that even though we might be exercising at very, very high intensity, nevertheless, blood pressure overall, especially mean blood pressure, doesn't rise all that much. Just like we've seen with blood gases, our parameters, our internal parameters, are relatively stable despite changes because they counterbalance each other. But it's not enough to say that they counterbalance each other just intrinsically. This is an active control and an active reflex paradigm. And that's why we learned about the baroreceptor reflex when we did. We do see a rise in mean arterial pressure, but it can be sustained, and we're not actively counteracting it when we are exercising. And so there is this reset of operating point during exercise. And there are some theories behind this, and we're not going to dig too deep into this. Understand that it's a combination of sympathetic and parasympathetic input, but it is also a combination of physical input, that if we have increased vascular return because of muscle contraction, changes in signaling. If we're creating organic acids and making metabolites, that can be sensed by the brain and responded to, whether it's nervous control or hormonal control in the case of sympathetic activity. Remember epinephrine and norepinephrine? All right. There are theories here, and we're still working some of these mechanisms out. Maybe it's something having to do with the central nervous system changing this threshold, okay, changing the set point. That's not unprecedented. If we look at when we have fever, what's happening in fever is we actually change the thermoreceptor threshold. There may be some things like we talked about with neuronal transmission. Remember gate control theory? This is similar to gate control theory, only it's more, the gate is more general, and that is to say the central nervous system may block synaptic transmission. There is some evidence for that, sort of like gate control theory. Muscle chemoreceptors, again, may be sensitive as well. I'm sure all of these mechanisms are at play. But the main point of this slide is to show you that when we do change blood pressure, we're actually changing the set point. We're not actually deviating from homeostasis per se. But like ventilation, heart rate, blood pressure, and some of the other sympathetic type responses that we see are often initiated feed-forward fashion prior to the actual stimuli. Now this will feel a little counterintuitive right here. What we think is happening is that when we exercise, these signals from muscles and joints get sent up to the central nervous system, which can then send signals back to exercising muscles, to the cardiovascular control center, the respiratory control center, and the limbic system. So what happens is these exercising muscles not only are setting up the possibility of feed-forward responses with exercise. So as we exercise more, we set up this infrastructure for the potential for feed-forward responses. All right. If you were to take a newborn and somehow stimulate it to undergo exercise, we wouldn't see a lot of these feed-forward mechanisms. These things kind of come with experience and understanding. So this model system is predicated on the idea that we have memories and we have an understanding of what's going on. As a sort of an aside, when we see deviations from this, we can then use that as potential diagnostics for neuromuscular or neurocognitive disorders. So issues with gait, issues with exercise, issues with coordinated movement, so forth. But it is fundamentally the sympathetic side when we're talking about moving into exercise, and parasympathetic when we're moving out of it. So I'm kind of bringing us back a little bit. So if you think about what's happening in the sympathetic system and then applying it on the paradigm of exercise. So we're all familiar with heat when it comes to exercise. Our bodies get warm. That's due to metabolism. A big chunk of that is actually citric acid cycle, generates a lot of heat. All right. Glycolysis can generate heat as well, but citric acid cycle does a lot of this. But that can be a challenge. We're departing from our homeostatic temperature, which means that we have the potential to impact enzymatic function in the cells. So we're going to countermand that with negative feedback pathways, a sweating response, what we call evaporative cooling. All right, the heat of evaporation, a lot of heat required to turn water into gas or water into water vapor. The problem, though, is that you're losing blood volume when you do this. By removing fluid, you have the potential for inappropriate ion concentrations, reduced blood volume, and reduced blood pressure, which is a problem when you have increased metabolic need. We also will get, this is part of the systemic vascular response, is that we get increased blood flow to the outer surface of the body. This is what we call a convective way of removing heat. With contact with air leads to a convective reduction in heat. Problem though, we're diverting blood from muscles when we do this. All right, we're diverting blood flow. And if we have a combination of dehydration, reduced blood volume, if we have a diversion like this, we may have issues down the line. That is to say, in order to maintain blood flow to the brain, we might actually become decompensatory with other systems. When we talk about heat exhaustion, that's often an excess of sweating in convective situation. But if we're talking about heat stroke is very, very different. Heat stroke is an effort to maintain blood flow to critical organ systems. And so we abandon thermal regulation in that situation. And that's why temperatures spike, because it's better to be too hot than to not have enough blood flow to critical organ systems like the brain, the heart, and the kidneys. So heat stroke is the decompensation of thermal regulation. So loss of salt, heat stroke danger, certainly heat exhaustion. Loss of salt is often in the heat exhaustion side of it. We can acclimatize, that is to say, as you are in a given temperature paradigm, especially for long periods of time, more than a few weeks or a few months, your body can and does acclimatize. Honestly, I believe that's one of the major problems that we are not recognizing when it comes to climate change, is that in the wintertime, we're not adapting to the cold as well. And so all we ever hear about is people complaining, oh, it's too cold, it's too cold. Well, we haven't adapted to it. We never get a chance to adapt to it because the next few days it might be 50 or 60 degrees after it's been below zero. And that's a problem, not only for ourselves, but for other mammals and other organisms in this rapidly changing climate. Acclimatization is an important aspect of physiology. We haven't had a chance to talk about it very much. But what we mean by this, for instance, loss of salt, our kidneys can adapt. Loss of fluid, our kidneys can adapt. Our heart and our blood vessels can adapt. Our behavior can change with acclimatization, et cetera, et cetera. There's a lot to talk about here. I just don't have time, but it's a major aspect in your future when you're dealing with people is this idea of helping people acclimatize. And we know about exercise and health. It's been drummed into us probably since we were young kids in school. We all know about that. We all know about the fact that cardiovascular disease risk drops with exercise. It will not eliminate it. There have been some very, very elite athletes that have had issues with cardiovascular disease, and that's secondary to other risk factors, genetics, and sometimes diet. What we are going to do is we're going to discuss a little bit about type 2 diabetes, just a little bit, just as an example of this, to drill a little bit more into this. So this is going to be one of our sort of our poster child situations because it's so prevalent in our society. What we call metabolic syndrome, pre-diabetes, is rampant in our society. And we'll talk a little bit about stress in the immune system over the next few slides. All right, it can be influenced both positively and negatively. Benefits of exercise, we've all heard about this. It can help with repair, improve memory, attention span. I've really worried about, I have noticed issues with attention span in just the year that we've had COVID because people have been a lot more sedentary during this time. So balancing your schoolwork and your professional lives with exercise is going to be really, really important. It can help stimulate growth of new nerve cells. We don't often think of the fact that we can grow new nerve cells. Certainly angiogenesis and better capillary density, but lots of allegorical benefits that we know about, and just in the nervous system. Let's look at glucose and insulin secretion. A normal person, if given a glucose challenge, will rise and then fall over the course of about 3 hours. It'll balance out. All right. This is your standard glucose tolerance test. The green and the red here are diabetic patients. So this is our healthy patient. We get a rise in blood glucose following a meal, up, maxing out usually around 30 minutes, and then it will sort of even out over time. We'll sort of see this sort of circadian type situation. A type 2 diabetes with no exercise, what we'll see is they have elevated blood sugars to begin with, and their blood glucose challenge leads to a really, really high blood glucose that doesn't even respond well after 3 hours. Sometimes you'll see it arc out even over 5 or 6 hours. This elevated glucose is really, really damaging. Leads to a lot of ancillary tissue damage. But if we have type 2 diabetics who undergo an exercise regimen, they can and do improve their glucose handling. Doesn't get us all the way back to our control levels, but it is significant and it does lead to diminished risk of comorbidities. All right. Insulin, we see, again, no exercise. We see, again, higher levels of insulin that the body doesn't respond to. You're not seeing much response here. Control levels, you see insulin and then you see it balance out. With exercise, we see a diminished insulin response. And insulin we know about in terms of blood glucose handling. But what you don't know is that insulin also behaves like a growth factor and influences tissue growth, including cardiac growth. A lot of diabetics have what we call is cardiac hypertrophy, and in part driven by hyperinsulinemia. So exercise not only improves glucose handling, but also reduces insulin load inside diabetic patients. Really, really good stuff. And it doesn't have to be high intensity exercise. 30 minutes of mild to moderate exercise a day can and does have an effect. But let's take this to the next level. Yes, we can know about insulin and glucose, but you're going to be dealing with patients who are going to be on insulin and insulin type therapies. You're going to be dealing with patients who are on these drugs that are managing their diabetes, and it's not just insulin. So as a healthcare provider, you ought to know a little bit more than what a person can do with a few minutes of Googling, okay? Well, here's our insulin pathway, and then when we have elevated blood glucose, it triggers the pancreas to release insulin. And insulin then binds insulin receptors, and we get see these little circles with the P's? That's phosphorylation. Remember the autotyrosine kinase phosphorylation. That leads to secondary forms of phosphorylation. This in total is called a phosphorylation cascade. This protein right here, this AS160, seems to be involved with vesicular translocation of vesicles that have the GLUT4 transporters. Now, this is not a very good picture. These transporters here are actually embedded in the membranes of these vesicles. So these vesicles are inside the cell, AS160 gets turned on, and we are migrating these vessels and fusing them with the plasma membrane to allow glucose to come in. So we are having, it's like exocytosis, if you will. We are moving to the plasma membrane those transporters, and that allows more glucose to come in. And that's great. But with exercise, what we see is we no longer need insulin to do that. Other metabolites, other signaling molecules, reactive oxygen species, okay? Nitric oxide, other phosphorylated proteins, okay, can lead to activation of this guy and translocation. So we can do this without increasing blood sugar. We can do this without insulin, and so we get the benefits. And that's next level. That's where you need to be. You don't have to know every single thing about this unless you're specializing. But having that additional information gives you an added layer of understanding and the ability to nuance sometimes what patients will figure out on their own. You're there to help your patients, and many of them will draw conclusions prematurely or draw conclusions absent of nuance. Just look at the vaccine responses. Just look at how COVID, has been handled in our country. You're seeing that in spades, and the inability to articulate nuanced points has been really a real challenge for health professionals and healthcare providers. So we got to get better at it. One way to get better at it is to understand that system. Just a little bit about immune system and exercise, and I've got two extremes here. And when it comes to exercise, we are creating a form of cell stress. We're creating a level of stress. But even this down here, this type of behavior is also stressful in its own way. What they have in common is a stress hormone known as cortisol. And when cortisol levels rise, and again, this is a hormone, so it's going to be released, and the release of cortisol is going to then bind to receptors in target tissues, which include the muscle, pancreas, fat, bone, and liver. Let's look at bone specifically. We can't do all of these. A little bit of cortisol when it comes to exercise is beneficial. So let's look at this chart right here. All right. This is an idea of homeostatic window, that if we have a little bit of stress in the form of exercise, we get optimal benefits. What we don't see here is that somebody who is incredibly sedentary, and this is one of the reasons why I don't want you doing Zoom from bed, okay? Get out of bed, move around, exercise a little bit. Why? Because cortisol, absent of other hormones, like for instance insulin, okay, or high triglycerides, high sugar, high insulin with cortisol, can lead to inflammation. All right, compromised immune system. So inflammation, more cortisol, compromise. Decreased resistance to stress, loss of sleep can all be detrimental. What happens is when you exercise, you no longer your blood sugar drops, okay? Your insulin levels drop, you get a little bit of cortisol, and now we're in the sweet spot. Okay? We're also reducing inflammatory white blood cells because cortisol is actually a mild anti-hematopoietic. So over here, this guy may have elevated inflammatory cells, triggering inflammation, leading to cardiovascular disease, certainly diminished cognitive function. Okay. When we have just a little bit of cortisol absent of some of these things, we can suppress some of those inflammatory white blood cells. The problem is that if we start exercising too much, and there's an ultra marathoner for you, all right, it can lead to ancillary issues. We can lead to cortisol dysregulation, which leads to problems in all these other tissues, all right? It can lead to immune suppression. One of the problems with folks who are ultra marathoners is that they often get sick. When I was swimming and we were doing 20,000 or more yards a day, I was getting sick all the time because we were exercising probably too much, and some other issues out there. So again, there's a homeostatic window here. Certainly, most regimens for human beings will fall into the optimal area. But there are those folks out there that can and do push the limits, and that can be excessive. So like all things physiologic, we have a homeostatic window, and cortisol is no exception. And here's the evidence from your book that a sedentary lifestyle, and this is incidence of urinary tract infections, URIs, urinary tract infections. We can see that in sedentary people, we have an elevated, relatively speaking, that with moderate exercise regimen that drops, but strenuous exercise, we begin to see a spike, getting that sort of homeostatic window. And a lot of this is mediated through cortisol. So in summary, we've put all of the pieces together, okay? Reinforce are things that we've learned about from our cell biology in early parts of the semester in exercise. When we talked about chapter 17 and 18 in response in dealing with exercise, myoglobin and hemoglobin. Cardiovascular responses, that was chapter 11, chapter 14, chapter 15, and a little bit of chapter 18, okay? Feed-forward responses, way back in Unit 1, all right? Temperature regulation, again, that's probably homeostasis, early Unit 1, so forth. And then finally, exercise and health. Again, some new stuff here, stuff we already know about, but then hormone signaling, chapter 7, okay? So in signaling, chapter 6. So it's all here. It keeps coming back on itself. And that's the beauty of physiology. That's also the challenge. Many of you probably have felt overwhelmed at times in a class like this. Get used to that feeling, because when you go on to graduate school, the material accelerates. This idea of simple things integrating together these emergent properties are all part of the issue of the complexity that is human biology, human physiology, and medical and healthcare. The body is amazingly elegant in its responses. It can do things in very, very simple ways to manage powerful problems. But if we aren't keeping the connections in mind, you're going to sometimes cause problems trying to solve problems. And that's the goal here, is to keep you guys thinking about the holistic person, what's going on in the physiological realm, and all of these things. I wish you all the best. Please reach out to me if you have any questions. Thank you for your time. Good luck, and I'm looking forward to seeing what you guys accomplish in the future. Thanks.